You asked for it, so here it is, the aromatase inhibitors deep dive for men aiming to control their serum estradiol levels between the middle to the top of the reference range, or slightly superphysiological, but definitely not in the gynecomastia or libido-destroying ranges, or titanic weeping territory. Are aromatase inhibitors the devil, or are they perfectly safe and used responsibly? Keep watching to find out. Vigorous Steve here. Alright, so we already addressed every compound you could possibly take which are known to reduce serum estradiol levels, but are technically not medically used aromatase inhibitors, some of which are available over the counter, some you can easily get on prescription, or otherwise you can easily find them online without a prescription. I'll link that video at the end of this one. In this video, we're going to review all of the scientific evidence performed on men using medically used aromatase inhibitors, not postmenopausal women suffering from estrogen-positive breast cancers. Man, it's getting old fast. Just regular, healthy men aiming towards estradiol management, whether they need it medically or to optimize their hormone replacement therapy protocol. Again, we're just looking to use aromatase inhibitors when needed to keep our serum estradiol levels between the middle to the top of the reference range, or maybe slightly superphysiological, whatever number on paper you feel best with. We're not aiming to crush our serum estradiol levels into a black hole of apathy and asexual misery. So let's get started with a brief rundown of what the medical aromatase inhibitors actually are. In case you're not up to speed, we have the first generation aromatase inhibitors, aminoglutamide, better known as Cited, and Testolactone, better known as Teslac, which has already been discontinued. Cited is still being prescribed in the treatment of seizures, Cushing's syndrome, breast cancers, prostate cancers, and it is a reversely binding aromatase inhibitor, which means that Cited enters the aromatase enzymes, stays there for a certain period of time, prevents the conversion of testosterone into estradiol, nandrolone into estradiol, trestolone into 7-alpha-methyl estradiol, or dianabol into methyl estradiol. After a while, it exits the aromatase enzymes, allowing it to go about their business, again converting androgens into estrogens. And Testolactone was prescribed in the treatment of advanced stage breast cancers. It was a steroidal suicide inhibitor, which means it enters the aromatase enzyme, gets stuck due to its chemical composition being very similar to androstenedione, and then this aromatase enzyme is no longer active to the point it gets metabolized from the body. And there were the second generation aromatase inhibitors, both of which have already been discontinued. Vigorous, better known as Efefma, used in the treatment of breast cancers, was a reversely binding aromatase inhibitor, and Exemestane, better known as Linteron, used in the treatment of estrogen-positive breast cancers in postmenopausal women, and as a second-line therapy after tamoxifen. It was a steroidal suicide inhibitor, both of which are no longer being used in medical settings. In this video, we'll be focusing on third-generation aromatase inhibitors, which are still available to this day and are being used within the bodybuilding community, the fitness community, the hormone replacement therapy community. Anastrozole, better known as Arimidex, a reversely binding aromatase inhibitor, Exemestane, better known as Aromacin, a steroidal suicide inhibitor, and Letrozole Femara, being used occasionally when Arimidex or Aromacin aren't really available or towards the end of a contest prep, or reversely binding aromatase inhibitor. So let's get started with the medical applications of Pfizer Aromacin. It's used as an adjuvant treatment of estrogen receptor-positive early breast cancer in postmenopausal women after 3 years of tamoxifen Nolvadex treatment, which is a selective estrogen receptor modulator, or it's used as a treatment of advanced breast cancers in postmenopausal women following unsuccessful tamoxifen treatment. The clinical dosage is 25 milligrams per day. The estradiol suppression observed in men using this clinical dosage of 25 milligrams Aromacin daily is 35%. Now, this suppression is based on the endogenous testosterone production, not on superphysiological testosterone coming from exogenous sources or HCG or enclomiphene monotherapy. And with women, postmenopausal women that is, the estradiol suppression is 97.9% with the clinical dosage. So there's a huge discrepancy here already between healthy men using endogenous testosterone, preventing the conversion thereof, and postmenopausal women with bottomed out testosterone and bottomed out estradiol levels, as we'll get into a little bit later on in this video. Pfizer Aromacin comes with the common side effects, including loss of bone mineral density, cardiovascular disease and events, hot flashes, joint pain or stiffness, increased sweating, hair loss, high blood pressure, insomnia, nausea, lethargy or fatigue, gastrointestinal upset, depression, headache, muscle pain, edema, increased appetite, vitamin D deficiency, and impaired Fertility. All of these common side effects are observed in postmenopausal women using the clinical dose of Aromatase against their estrogen receptor positive breast cancers, right? Keep this in mind going forward. And the medical applications of AstraZeneca Arimidex are actually very similar to Pfizer Aromatase as an adjuvant treatment of estrogen receptor positive early breast cancer in postmenopausal women, often alongside tamoxifen treatment, or the treatment of advanced breast cancers in postmenopausal women when tamoxifen treatment was unsuccessful. The clinical dosage is 1 milligram daily, and it is 1 milligram daily dosage. The estradiol suppression in men is between 29 to 34%, and in women, 96.7 to 97.3%. Right? Their testosterone and estradiol levels are significantly different between healthy men and postmenopausal women. Now, the main problem with the anastrozole compared to other aromatase inhibitors, not only does it inhibit the metabolism of testosterone into estradiol, it also inhibits the metabolism of cholesterol into 27-hydroxycholesterol, which is needed for bile acid synthesis. Anastrozole also inhibits the sterile 27-hydroxylase enzymes in a reversely binding fashion, similarly to the aromatase enzymes. So that means you might get constipated. If bile acid synthesis goes down, not only do you prevent the lubrication of your stool, you also reduce your ability to excrete metabolic waste products and toxins from the body. And by inhibiting cholesterol metabolism, you see that total cholesterol levels and low-density lipoprotein levels slowly start to creep up for the same level of estradiol management compared to other aromatase inhibitors. So let's say you want to bring your serum estradiol levels from 60 picograms per milliliter to 40, nicely at the top of the reference range. With anastrozole, you see that your total cholesterol levels and LDL levels start to come up more in comparison to Aromatase for the same level of estradiol management. Right? Keep this in mind when you choose aromatase inhibitors. The common side effects of AstraZeneca Arimidex are on the screen. They're actually very similar to Aromatase. And again, all of these common side effects are stemming from the medical dose when administered to postmenopausal women suffering from estrogen-positive breast cancers. Moving over to the medical applications of Novartis Femara, very similar to the other medical applications, as an adjuvant treatment of estrogen receptor-positive early breast cancer in postmenopausal women after 5 years of tamoxifen treatment, or as a treatment of advanced breast cancers in postmenopausal women following unsuccessful tamoxifen treatment. The clinical dose is 2.5 milligrams daily. At this clinical dose, the estradiol suppression in men is between 42 to 62%, which is significantly higher compared to the other reversely binding aromatase inhibitor, anastrozole, but that's also because the clinical dose is 2.5 times higher. Anastrozole is 1 milligram per day, and letrozole is 2.5 milligrams per day. In women, at the clinical dose of 2.5 milligrams daily, the estradiol suppression is between 98.9 to over 99.1%. So that's pretty freaking brutal. So you could consider the 2.5 milligram dose to be the highest estradiol suppression in both men and women. And here are the common side effects of Novartis Femara, again established on postmenopausal women suffering from estrogen-positive breast cancers when administered with the clinical dose of 2.5 milligrams letrozole daily. Let that scroll a little bit, and let's start comparing these commonly occurring side effects of aromatase inhibitors to the symptoms of postmenopause, in which case serum estradiol levels are below 10 picograms per milliliter already. Postmenopausal women, common symptoms: loss of bone mineral density, cardiovascular disease and events, hot flashes, vaginal dryness, joint pain or stiffness, increased sweating, hair loss, dry skin, insomnia, nausea, lethargy or fatigue, depression, headache, muscle pain, edema, infertility, cognitive decline, and dementia. So when we start comparing the side effects to postmenopause, it's pretty much overlapping, right? Am I mistaken here, or are the side effects associated with aromatase inhibitors almost identical to the symptoms of postmenopause? Right? I'll leave it up to you. You be the judge. You can start comparing using the timestamps. But as far as I'm able to tell, everything pretty much overlaps besides gastrointestinal upset, diarrhea, and nausea, which in many cases you can mitigate by not overdoing the aromatase inhibitors and taking care of your health accordingly with over-the-counter supplements and following particular lifestyle choices regarding your diet. And again, choosing exemestane over anastrozole, which otherwise inhibits bile acid synthesis, might already offset these terrible side effects associated with aromatase inhibitors by keeping the intestinal lubrication and stool excretion up to par as where you expect it to be. And let's be honest here, cognitive decline and dementia is also highly related to general aging and lifestyle choices throughout the entirety of life. When you look at the sample of postmenopausal women that are currently undergoing cognitive decline or dementia, whether they have estrogen-positive breast cancers using aromatase inhibitors or not, they come from a generation where smoking and drinking was generally accepted. Did the smoking and drinking put them in chronic oxidative stress, resulting in dementia and cognitive decline, or estrogen-positive breast cancers forcing them to use aromatase inhibitors and suffering from cognitive decline while using aromatase inhibitors? I mean, it remains to be debated, right? I don't think that cognitive decline or dementia is solely related to declining or lowering serum estradiol levels or overall estrogen levels in the body, whether that's in men or women. I think there's a lot of cofactors at play here. Now, to better understand these common side effects of aromatase inhibitors and the symptoms of menopause, we can look into the reference ranges of both estrone and estradiol in both men and women. And you see here that estrone in men commonly is throughout the entirety of life between 10 to 60 picograms per milliliter, whereas women pre-menopause, it's between 17 to 200 picograms per milliliter, but post-menopause, it drops to 7 to 40 picograms per milliliter. So that's a steep reduction between pre-menopause to post-menopause. And post-menopause, it's actually lower than estrone levels in men. And it's the same for estradiol. In men, throughout the entirety of adult life, it's between 10 to 44 picograms per milliliter. And again, using aromatase inhibitors, I would aim towards, let's say, 20 to 25 to 40, 44 picograms per milliliter, or maybe even 50, 55 if you can tolerate that. Whereas with women, pre-menopause, it's, significantly higher, between 15 to 350 picograms per milliliter. But post-menopause, it's undetectable, below 10 picograms per milliliter, which is below the reference range of adult men. Yes, postmenopausal women have lower estradiol than men around the same age. Keep this in mind going forward. And when aromatase inhibitors are used in postmenopausal states, estrone and estradiol levels are undetectably low. So if we go with the clinically used dose of any aromatase inhibitor, anastrozole, exemestane, or letrozole, and we lower serum estradiol levels over 96.7%, and the serum estradiol was right at the border of the reference range in postmenopausal women, creeping up against 10 picograms per milliliter, that means that serum estradiol levels end up below 0.33 picograms per milliliter. I mean, man, dude, for all of the coaches out there, they can confirm that serum estradiol levels in bodybuilders right on the day they step on stage are not that low after abusing aromatase inhibitors and selective estrogen receptor modulators, being tamoxifen, which has a metabolite norendoxafen, which is also a potent aromatase inhibitor. It is not that low. It's maybe 2, 4, 10 picograms per milliliter, which is more than low enough to have a favorable outcome regarding body composition and overall conditioning, allowing you to drop as much water as possible when needed to step on stage. In bodybuilders abusing aromatase inhibitors, serum estradiol levels are not undetectably low, certainly not 0.33 picograms per milliliter, right? Keep this in mind, guys. Please, when you do research, keep this in mind. So let me reiterate yet again, I think it's safe to say, as long as you don't crush your serum estrone and estradiol levels to undetectable levels abusing aromatase inhibitors, that none of the commonly occurring side effects associated with aromatase inhibitors are going to occur for you, right? You have to be smart, you have to play it safe. We're using these aromatase inhibitors to reduce serum estradiol levels to favorable ranges for men, which in my opinion is between the middle, let's say 20 to 25 picograms per milliliter, to the top of the reference range, around 40 to 44 picograms per milliliter. And for the guys that are out there that want the most amount of growth hormone secretion and IGF-1 secretion downstream by keeping their serum estradiol levels at, let's say, 50, 55, maybe even 60 picograms per milliliter, go right ahead. They use a low and effective dose of an aromatase inhibitor, just slightly, to bring those serum estradiol levels into favorable ranges for them as an individual. Let's have a look at the medical applications of aromatase inhibitors in men. Again, these are all considered to be off-label prescriptions. Aromatase inhibitors are used in the treatment of familial aromatase enzyme overexpression, where aromatase enzyme and conversion of testosterone into estradiol is just sky-freaking high. In the treatment of short stature in children, often combined with growth hormone and or oxandrolone, better known as Anavar. Aromatase inhibitors are also used in the treatment of elderly androgen deficiency. There's actually a lot of studies which investigate that. All of the citations you can find down below, but let me give you a summary. Men aged between 62 to 74 years old saw an increase in prostate-specific antigen levels when taking 1 milligram anastrozole 2 times weekly up to daily, which might be correlated to an increase in serum dihydrotestosterone levels, which is a known side effect of using aromatase inhibitors. Obviously, if you prevent the conversion of testosterone into estradiol, then the potential for testosterone to convert into dihydrotestosterone increases. A follow-up study of the same subjects also showed skewed lipid parameters. However, some of these patients were smokers or past smokers and used either aspirin or statins or both during anastrozole treatment, which kind of raises the question, what came first, androgen deficiency or lifestyle choices filled with statins to offset these terrible lifestyle choices, right? When 2 milligrams anastrozole is administered daily to men aged between 57 to 77 years old, there's a significant reduction in nighttime growth hormone pulse, amplitude, and overall growth hormone levels. Now, of course, in this study, serum estradiol levels are also crushed. I mean, what do you expect with 2 milligrams anastrozole daily? And we do know that serum estradiol has a contributing, secreting role to growth hormone and IGF-1 levels. And I think the study also showed a loss of bone mineral density, but we'll dive into that a little bit later on in this video because it's important to highlight. And remember when I said I wasn't going to review postmenopausal women studies? I lied. There's one study where postmenopausal women received testosterone treatment with letrozole to control aromatization, and there appears to be no adverse effects. Libido generally improved, and there are significant improvement in concentration as well as visual and verbal memory. All of these are linked to the testosterone. Letrozole had no adverse effects. So this is as close to a testosterone replacement therapy protocol with letrozole that we're going to get, albeit in postmenopausal women, which would otherwise have crushed testosterone and estradiol levels. Again, if you're interested, all of the citations are down below. Aromatase inhibitors are used medically for estradiol management during testosterone or hormone replacement therapy protocols. Duh. In the treatment of infertility or subfertility, albeit that it's less effective than Clomid and Clomiphene, human chorionic gonadotropin, and follicle-stimulating hormone. Aromatase inhibitors are used in the treatment of gynecomastia, albeit that it's less effective than surgery, tamoxifen, or raloxifene, obviously. In the treatment of metastatic estrogen-positive breast cancers in men, where it's less effective than tamoxifen, albeit that there's not so many cases where estrogen-positive breast cancers are present in men. And aromatase inhibitors are used in the treatment of estrogen-positive prostate cancers in men, albeit that they're less effective than gonadotropin antagonists, like triptorelin, for example, which will basically castrate you. And with that out of the way, let's have a look at all of the available safety data performed on men using aromatase inhibitors, starting with Exemestane. In this study performed by Maurus et al., published in December 2003, titled Pharmacokinetics and Dose Finding of a Potential Aromatase Inhibitor, Aromacin, Exemestane. In this study, they investigated healthy male volunteers between 14 to 26 years old, and they received 25 milligrams or 50 milligrams aromacin daily for 10 days, followed by a 14-day washout between the two treatments. Baseline blood work parameters were compared to the blood work results taken at the end of each 10-day aromacin treatment. In both groups, serum estradiol decreased between 32 to 38%, sex hormone-binding globulin decreased between 19 to 21%, and serum testosterone increased between 56 to 60%, indicating that the 25 milligram aromacin dose daily is sufficient to achieve the desired result with endogenously produced testosterone, where serum estradiol levels come down and testosterone levels come up. When you scroll down to table 2, you see that there's a significant reduction in IGF-1 levels, which is to be expected when you reduce your serum estradiol levels, albeit that the reduction in IGF-1 is more pronounced at the 25 milligram dose for a 10-day treatment compared to the 50 milligram dose. Triglycerides stayed pretty much comparable. Total cholesterol levels stayed pretty comparable. HDL comparable, and LDL levels comparable, but that's very likely due to the short duration of this treatment. And of course, this is a short-term study in adolescents. What we're after is longitudinal data in adults. And this study basically describes exactly what we're after, albeit not on the aromatase inhibitors that we generally use in bodybuilding. Performed by Zamuda et al., published on April 1993, titled The Effects of Testosterone Aromatization on High-Density Lipoprotein Cholesterol Level and Post-Heparin Lipolytic Activity. In this study, 14 healthy adult male weightlifters with an average age of 27 years old received either 200 milligrams testosterone enanthate intramuscularly weekly, 2.5 milligrams oral testolactone, Teslac, which is no longer available. It's a suicide inhibitor. Again, it's discontinued. 4 times daily for a total 10 milligram per day dose, or both 200 milligrams testosterone enanthate intramuscularly weekly, plus 2.5 milligrams testolactone 4 times daily for 3 weeks of treatment, followed by a 4-week washout period before the next treatment began. The researchers tracked changes in body weight and blood work parameters related to liver function. Obviously, serum testosterone levels increased during all treatment, but increased the most during the testosterone plus testolactone treatment. As expected, smart particle high-density lipoprotein ApoE-A1 and total cholesterol levels decreased, while low-density lipoprotein and ApoE-B levels maintained relatively similar to baseline readings. And triglycerides increased slightly, albeit insignificantly so. While body fat levels did increase due to the testosterone treatment, there were no alterations in both liver function and blood pressure measurements during the study. Now, the study is obviously performed on testolactone, which is discontinued and no longer used in the fitness community, and it's only a reasonably short duration of time, 3 weeks of the testosterone enanthate plus testolactone treatment, but at least serum estradiol levels weren't bottomed out, unlike many of the other studies performed on aromatase inhibitors. And maybe we can extrapolate a little bit of safety and efficacy data of testolactone and translate that to Exemestane, which is also a suicide inhibitor. There's another study which looked into anastrozole intervention during testosterone replacement therapy, showing that men successfully kept their serum estradiol levels around 22 picograms per milliliter, which is basically the middle of the reference range, but a little bit too low for comfort, in my opinion, when you're after testosterone or hormone replacement therapy protocols regarding optimization. They did this with a starting dose of 0.5 milligrams anastrozole 3 times weekly, albeit that dosage adjustments did take place during the treatment, but unfortunately they didn't track any adverse effects of these treatments, but the citation is down below in case you're interested. There are 2 other papers which I would like to highlight, which basically go over all other studies previously performed on men of different ages using aromatase inhibitors for various medical conditions, including short stature, androgen deficiency, obesity, gynecomastia, and even certain cancers. This first one is performed by Deronda et al., published on June 21, 2011, titled Aromatase Inhibitors in Men, Effects and Therapeutic Options. When you scroll down to the safety and concerns segment of this paper, the authors mention that third-generation aromatase inhibitors like anastrozole or letrozole cause major side effects in postmenopausal women who are treated for estrogen-positive breast cancers, like I highlighted at the start of this video. In most of the studies performed on men, estradiol levels decreased only slightly, usually resulting in an increase of gonadotropin hormones like luteinizing hormone and follicle-stimulating hormone when aromatase inhibitors are administered to men not using exogenous testosterone replacement therapy, which raises testosterone and thus estradiol levels downstream, which you're controlling then with the use of an aromatase inhibitor. So basically, total testosterone, free testosterone, and luteinizing hormone and follicle-stimulating hormone levels go up while using aromatase inhibitors during androgen deficiency or other contexts to raise total testosterone levels, but estradiol levels stay under control. And while there is a concern of loss of bone mineral density in these androgen-deficient men, there seem to be little instances of this occurring in men using aromatase inhibitors unless serum estradiol levels are crushed for longer periods of time. And we'll get into this a little bit later on. Serum lipids might skew slightly, complete blood count parameters might go up, an increase in hematocrit and total red blood cell count, which is to be expected when there's an increase in total testosterone levels, as this is also seen on hormone replacement therapy protocols. So if you're already on hormone replacement therapy and you start using aromatase inhibitors, well, your lipids are already skewed. They might skew a little bit more, and your complete blood count might also be skewed. It might skew a little bit more because total testosterone levels are going to go up, obviously. And there's conflicting evidence regarding the effects of letrozole and anastrozole on cognition. No effects in adolescents, but minimal improvement of verbal memory on the elderly using hormone replacement therapy. So that might indicate that estradiol does play a contributing role in verbal memory in the elderly when they're otherwise androgen deficient and then transitioning into hormone replacement therapy, right? This increase in estradiol in that context might be warranted. And this review paper is a lot more recent, performed by Korani et al., published in January-March edition 2023, Aromatase Inhibitors in Male, a literature review. Unfortunately, it doesn't really go over the potential adverse effects of aromatase inhibitors, but it just lists the beneficial effects under various medical conditions, none of which, besides gynecomastia maybe, are conditions that fitness enthusiasts generally suffer from. The only concern of this paper, like many other papers mentioned beforehand, is the loss of bone mineral density. And there's actually a lot more studies that go over the potential adverse effects of aromatase inhibitors in men, whether they use exogenous testosterone hormone replacement therapy or not. But I think it's better if I just summarize all of those results instead of highlighting individual studies and making my editor go crazy. So here are the potential adverse effects of aromatase inhibitors in men. Loss of bone mineral density, which is, well, attenuated by exogenous anabolic androgenic steroids like testosterone, nandrolone, etc. Tamoxifen, Nolvadex, albeit that also lowers serum estradiol levels with one of its metabolites, norendoxafen. And I don't think that tamoxifen is very sustainable because of blood clots, reduction of IGF-1, and maybe emotional disturbances by activating the estrogen receptors in the brain. And the loss of bone mineral density is also attenuated by keeping your serum estradiol levels over 11 picograms per milliliter or 40 picomoles per liter. We'll get into that a little bit later on. Muscle or tendon tears by impairing estrogen-mediated collagen synthesis. Now, of course, muscle and tendon tears can also occur during a contest prep, especially towards the end, where aromatase inhibitors are generally abused if you cross serum estradiol levels to single digits, to get as lean and as shredded as possible, to lose the last little bit of body fat and to make the water loss a little bit easier before stepping on stage. And of course, Winstrol is also heavily used towards the end of a contest prep. So if estradiol contributes to collagen synthesis and you take Winstrol, which alters the ratio between collagen types, but you crush your serum estradiol levels, then obviously you're more susceptible to muscle tear. So I don't think this is something that you as an individual taking aromatase inhibitors, keeping serum estradiol levels between the middle to the top of the reference range, has to worry about. Hair loss. Always an issue with aromatase inhibitors by raising serum dihydrotestosterone levels. This is a valid concern. This can happen at any dose. If you reduce your estradiol levels, even ever so slightly, you increase the potential for a 5-alpha reduction of testosterone into dihydrotestosterone, which could contribute to hair loss downstream. Now, if this is an issue for you, then don't take aromatase inhibitors, obviously. And if you suffer from hair loss and you take a 5-alpha reductase inhibitor to bring your dihydrotestosterone levels down, then what is going to happen, right? Testosterone is going to aromatase into estradiol. Your estradiol levels are higher, and now you have gyno. Right? You can't win. So if you're worried about hair loss, topical solutions only. Don't take exogenous testosterone replacement therapy because you're going through this roller coaster of aromatase inhibitors, 5-alpha reductase inhibitors, hair loss, gynecomastia, and maybe you are able to mitigate your hair loss and your gynecomastia, and now your doesn't work. So you're going to have to sacrifice something, bro. Skewed lipid parameters and cardiovascular disease. Again, like I mentioned before, anastrozole inhibits cholesterol metabolism and thus total cholesterol levels and low-density lipoprotein levels go up to a higher degree compared to Exemestane, right? So if you have to make a choice, go with Exemestane. And if you're worried about skewed lipid parameters and cardiovascular disease, stay away from synthetic carrier oil, which raise your high-sensitivity C-reactive protein levels to the moon. And well, stay away from steroids in general because they will all skew your lipid parameters. I don't think that a little bit of Exemestane on top of your steroid cycle is going to skew your lipids any more than all of the steroids that you're already taking. And otherwise, well, we have the fish oil, the citrus bergamot, the ezetimibe, the daily fasted cardio, the healthy eating, right? Don't underestimate following a healthy lifestyle. It is always a concern that aromatase inhibitors can cause cognitive impairment and neurodegradation, and it can raise the neurotoxic and cardiotoxic potential of testosterone, nandrolone, dianabol, and trestilone by inhibiting conversion of testosterone into estradiol, nandrolone into estradiol, dianabol into methylestradiol, and trestilone into 7-alpha methylestradiol, which might be inherently more neurotoxic or cardiotoxic because the aromatization is impaired. Now, I think all of these potential adverse effects should be a non-issue if you aim to keep your serum estradiol levels to the middle, to the top of the reference range, and choose exemestane over anastrozole or letrozole because that seems to skew your lipid parameters more. Right? All of these things I think you can mitigate. Regarding the loss of bone mineral density, this effect has been studied in correlation with serum estradiol levels, where elderly men observe a loss of bone mineral density, where serum estradiol levels are sustained again below 11 picograms per milliliter, which is eerily close to the serum estradiol levels of postmenopausal women, which also experience loss of bone mineral density. So again, all you have to do is keep your serum estradiol levels over 11 picograms per milliliter, and I think this is a non-issue. There's a review paper that compares aromatase inhibitors to tamoxifen regarding the loss of bone mineral density, where tamoxifen treatment in postmenopausal women suffering from estrogen-positive breast cancers did not cause any adverse effects on bones, whereas aromatase inhibitors did increase the instances of bone fractures, and that's because tamoxifen can actually activate the estrogen receptors on bone tissue and cause some sort of bone mineralization or prevent cancellous bone turnover, where serum estradiol levels are reduced, right, in postmenopausal states or in cases of aromatase inhibition from the norendoxifen or aromatase inhibitors, right? I know it's a mouthful, but tamoxifen basically allows for bone mineral density to increase while serum estradiol levels are low because it has some estrogen-like effect. It's a selective estrogen receptor modulator after all. Again, this is based on bottomed-out estradiol levels, which is not something that we're aiming for more than 2 weeks leading into a bodybuilding contest. So these two studies are a little bit more applicable, and we can find out where these preventative estradiol ranges are actually stemming from. Performed by Burnett, Bowie et al., published in December 2009, titled Effects of Aromatase Inhibition on Bone Mineral Density and Bone Turnover in Older Men with Low Testosterone Levels. So this is not in the context of testosterone replacement therapy. In this clinical trial, they administered 1 milligram anastrozole daily to 69 men over 60 years old with clear symptoms of androgen deficiency. The researchers assessed bone mineral density of the patients at baseline, month 3, 6, 9, and 12 of the trial. Initially, serum testosterone and dietary testosterone levels increased, while serum estradiol levels and sexual binding globulin levels decreased significantly. However, after 12 months of treatment, all of these hormones slowly started to recover towards baseline levels, as you can see in the charts, indicating that there's some sort of adaptive response over time, whether that's an increase of aromatase enzyme expression in adipose tissue or an increase of anastrozole metabolism, that's unclear. You see here in figure 2 that serum estradiol levels declined from 15 picograms per milliliter at baseline to about 12 picograms per milliliter during the treatment, so they were already pretty low to begin with, which is, again, eerily close to postmenopausal levels. In women, the loss of bone mineral density of these elderly men during anastrozole treatment could have been prevented, obviously, if they kept the dosage considerably more moderate than the clinical dose of 1 milligram anastrozole daily, or if they combined this with hormone replacement therapy. Because, well, we do know that testosterone replacement or nandrolone treatment in elderly men prevents cancellous bone turnover, albeit in both instances, obviously, serum estradiol levels are significantly higher than 11, 12, 15 picograms per milliliter. Another study I want to highlight from Koshla et al., published in August 2001, titled Relationship of Serum Sex Steroid Levels to Longitudinal Changes in Bone Density in Young versus Elderly Men. Another interesting study that compares the effects of sex hormones on bone mineral density in young and older men, where serum estradiol levels below 11 picograms per milliliter were associated with higher rates of bone loss compared to serum estradiol levels over 11 picograms per milliliter in elderly men with declining sex hormone levels, right? So in the young men where serum estradiol levels are normal, there's no loss of bone mineral density, but in elderly men, especially men below 11 picograms per milliliter under serum estradiol levels, overall bone mineral density slowly comes down with time. Now, I can't remember for the life of me hearing any reports that there's spontaneously broken bones of anybody in the fitness industry ever. Sure, we have two instances where men, bodybuilders, do arm wrestling and then having a spiral fracture because they're not really up to par with their components. Ian Valliere and Victor Martinez spring to mind. But I think that's about it. And of course, we have a lot of torn muscles and ligaments and connective tissue in the fitness industry, but that's usually related to the winstrol and not adjusting their training intensity leading into a contest, right? So we have to take everything with a grain of salt and look into the total picture on when these issues start to occur. So I would say if you're really worried about the loss of bone mineral density, don't overuse the aromatase inhibitors. Don't crush your serum estradiol levels. And I think that you'll break your libido, you'll break your well before you break any bones, and then you go in for blood work and you see that your serum estradiol levels are below 15 or 11 picograms per milliliter, so you can take affirmative action, right? I think you break your libido well before you break any bones, or you have to worry about the loss of bone mineral density when you use aromatase inhibitors. Another study I want to highlight, performed by Phillips et al., published on February 23, 2011. Do aromatase inhibitors have adverse effects on cognitive function? This, unfortunately, has been performed on postmenopausal women, but it's still interesting regarding the potential neurotoxicity or neurodegradation and adverse effects on cognitive function. It has been studied and grouped into this meta-analysis, showing no statistically significant effects on cognitive function, besides a single study showing poorer verbal and visual learning in the anastrozole groups. But again, this is postmenopausal women with early-stage breast cancer receiving 1 milligram anastrozole daily, so we can assume that their serum estradiol levels are undetectably low. I think at this point, survival on cancer remission is a lot more important than overall cognition. And there are several studies which look into the use of anabolic androgenic steroids and the potential for aromatase inhibition in the brain, showing clear adverse effects. But I think it's best if I save that for a separate video discussing how steroids and ancillaries affect the brain, which I'll make once I finish with these steroid deep dives, hopefully by the end of this year. What I will say is that aromatase inhibitors could potentially increase neurotoxicity or excitotoxicity of the aromatazable compounds like testosterone, nandrolone, trestolone, and dianabol, as it prevents the conversion into estradiol, methyl estradiol, or 7-alpha. Methyl estradiol, we do know that estradiol is neuroprotective and acts as an antioxidant in the endothelial tissue, but it's unclear if that's the case for methyl estradiol or 7-alpha methyl estradiol. Of course, other compounds like trenbolone, winstrol, primobolan, and mastrone might just be as excitotoxic or neurotoxic, if not more, compared to testosterone. Trenbolone and winstrol has been directly compared to testosterone regarding its neurodegradating effects. We'll save that for the upcoming deep dive video about how anabolic androgenic steroids affect the brain, dropping before the end of this year. And while primobolan, mastrone, and maybe some of their metabolites might inhibit the aromatase enzymes in the brain and prevent the conversion of testosterone into estradiol and make the testosterone more neurotoxic and excitotoxic and reduce the neuroprotective effects of estradiol. So basically, you can't win when you take steroids. I think that all steroids are neurotoxic, whether they aromatize or not. And how these potential neurotoxic effects compare to something like alcohol, which is commonly consumed, available everywhere, and known to be neurotoxic at any concentration, those studies haven't been performed, and I don't think they ever will be. Would I rather avoid alcohol than aromatase inhibitors? The answer is yes. And to be fair, I have combined anabolic androgenic steroids with aromatase inhibitors and alcohol here and there on birthdays or holidays, and I'm still here, making high-quality content that is fully cited for you guys here on YouTube. And if you want to nitpick, even endogenously produced dihydrotestosterone is known to inhibit the aromatase enzymes, at least in several cancer studies. So if you're worried about neurotoxicity, are you now going to take 1 milligram finasteride or dutasteride daily to crush your dihydrotestosterone levels, allowing testosterone to convert into estradiol for potential neuroprotective effects and thus killing your in the process? I'll leave that decision up to you. You know what? I'm just going to throw this out there. Weirdly, all of the guys who are so dogmatic against the use of aromatase inhibitors are the guys with the clearest indication of neurodegradation and symptoms of neurotoxicity, with emotional disturbances representative of the use of the selective estrogen receptor modulators. All of the guys that I know that are in favor of intelligent use of aromatase inhibitors where needed when all other options have already been optimized are the most composed, the most intelligent, generally well-respected and well-balanced individuals in our space. Take from that what you will. For now, if you're still worried about the use of aromatase inhibitors, just keep in mind that there's a boatload of compounds out there that are known to inhibit the aromatase enzymes, but they're not medically used to crash serum estradiol levels. And there's a boatload of compounds out there that are known to reduce serum estradiol levels. So are you going to avoid all of these for the potential of loss of bone mineral density or skewed lipid or neurodegradation, which again hasn't even been studied in the context of many of these compounds lowering serum estradiol levels? I'll leave that up to you. You can use a dose of exogenous testosterone to the point your serum estradiol levels is at the top of the reference range and optimize that further by bringing your body fat levels down and increasing your injection frequency, and then get the rest of your anabolism from, dihydrotestosterone testosterone derivatives, which might inhibit the aromatase enzymes, or other dihydrotestosterone testosterone derivatives, which are not known to do that, but those are all oral steroids like Anavar, for example, very anabolic, but comes with its own set of prerequisites and deleterious effects in the long term, potentially, even though Anavar might be the safest oral steroid you can take. You can take growth hormone, IGF-1, insulin, then we're going into cancer realms. Right? So there are no free rides, dude. There are no free rides. Intelligent use of performance-enhancing drugs is where it's at, but you're going to have to combine several of them to get the desired results that you're most likely after. So here's a list of known aromatase inhibitors, might be in the context of certain cancers though. It hasn't been fully studied, but I still made a list for you guys. There's a boatload of them, so just going to highlight the ones that you might be familiar with. 1-androstenedione, abbreviated to 1-AD, androstadienedione, ADD, and Arimistane, ATD. These are boldenone metabolites. 4-AT, also known as 6-oxo, aminoglutamide, cytidrin, anastrozole, arimidex, boldenone, equipoise, and the metabolites which I mentioned earlier, dihydroboldenone, DHP, dihydrotestosterone, DHT, drostanolomastrone, and some of its metabolites, exemestane, aromacin, glucophage, metformin, ketoconazole, nizoral, letrozole from methanolone primobolan, and some of its metabolites, mestrolone proviron and some of their metabolites, nicotine and metabolites, animacine and cotinine, norendoxaphene, which is a tamoxifen metabolite, testolactone, Teslac, and again, some of the metabolites of primobolan, proviron, and mastrone might be potential aromatase inhibitors, but it hasn't been fully studied in this context, unfortunately, up until this day. We're simply going by blood work results of everybody in the fitness community. And there are several estradiol-lowering over-the-counter supplements and ancillaries, ascorbic acid, vitamin C, berberine, calcium diglucarate, dichoroinositol, diindolmethane, several fatty acids, glucophage, metformin, yet again, melatonin, tadalafil, cialis, valproic acid, also known as sodium valproate, retinol, vitamin E, THC metabolites, and tretinoin, all classified as terpenoids. Thyroid hormones, even T3 and T4, help with aromatase enzyme expression. And zinc. Food for thought. You thought it was going to be as easy as avoiding 3 medications that are classified as medical aromatase inhibitors? Think again. Go do your blood work over at Merck Health if you're worried about your serum estradiol levels, or do it anywhere else that is close by if you don't live in the United States. It's important for you to do your blood work so you can keep track of your serum estradiol, serum estrone, serum testosterone, serum dihydrotestosterone, and everything else that's important to you. Right? If you feel I left out a particular study or it's not cited down below, feel free to quote me. I'd love to see more research on this particular topic. I've done many days of research regarding deleterious effects of aromatase inhibitors when serum estradiol levels are maintained in adult men, and I see little deleterious effects that we can't circumnavigate with intelligent use. Thank you guys so much for watching. You can find everything that I'm associated with down below in the YouTube description section. Follow me on Instagram and TikTok at Vigorous Steve. Vigorous crew, you guys know what to do. A frontal bicep for you guys. I'm using Aromacin right now, and I'm not dead yet. Thank you guys so much for watching, and I'll see you in the next video.